My name is Samir Batra, and I am the founder and CEO of BAHA Enterprises. A lot of people ask me what BAHA stands for. Baja, California, except without the J, right? No, Andy, stop laughing at me. It's Bay Area Healthcare Advisors, or as somebody told me once, become a healthcare advisor. So a patient could be their own healthcare advisor. We work at the intersection of innovation and entrepreneurs. And honestly, we're helping groom the next evolution of cutting edge solutions. So we partner with investors and support them in their mission of finding the right technologies. And then we also partner with providers by literally just guiding them and giving them our opinion. As if some of you were in my session, heard me, we're pretty hard on our entrepreneurs to make sure that they're providing solutions that work. So, but no further ado, I'm gonna go ahead and have Dr. Lynda Davis introduce herself.
Thank you very much. It's hard to see everybody with these lights, but I guess that's my problem, not yours. Your problem is you have to look at that picture up there. It's great to be here. I had a really good customer experience, and it was indicative that I had some lunch this morning here, and I didn't like what I got in my meal. And it used to be that I would be quiet about it and I would grumble, I'm not coming back there again, and da-da-da-da. Well, the older I get, and that's considerably older, I know the value of speaking up. And so I was able to say what I didn't like. I got a positive reception, and I in fact had the chef come out, and not only did he listen, but he also gave me a box of chocolates. So I was rewarded for speaking up. And that's kind of what we're about here, is how do we give our patients the opportunity to speak up, to tell us what they really want, not just in their salad, but in their patient care, and to be listened to personally, and then be rewarded for even an improved experience in their care. So just a little bit about me. I am been around the block a lot, and started in the VA in my clinical practice in the 70s, and just like 70%, of our healthcare providers go through the VA. 120,000 a year from 1,800 different medical affiliated universities go through our system. So if they come out the other end and they don't know something about patient experience, I guess it's our fault. But you get the benefit of it because now we have a new system in place that is all about that culture change. At one point in my career, I went into the Army, and that transformed my trajectory. It's partly why I'm at the VA now. I am the Chief Veteran Experience Officer. It's an office that was started a couple years ago. We are really the first in the government, and we are the lead government-wide for not just patient experience, but for customer experience. It is exciting, and I'm not going to tell you anything you don't already know. I'm not going to geek out on the technology, but just let me tell you a couple things. And then we can talk afterwards. If you have any chocolate to share, I'll talk to you.
You have to share your chocolate. No?
No.
Okay.
No. So we are the largest integrated healthcare system in the country. You know that. $91 billion. We have 374,000 staff serving 9 million customers. Our veterans, that's only half of our potential customer base. There's about 20,000 veterans in the country right now. So we have a big enterprise, and luckily I don't have to count the budget and the dollars. Because each of you is a payer into that system, it's because of your tax dollars that we're able to take care of the 1% who raises their hand and goes to serve the rest of us. But what we're doing now in the VA, and I sincerely want to open this up to a dialogue because we are learning with and from you, okay? And I hope maybe you could learn a little bit from us, but the most important thing is for me to listen to you all. And our secretary and OMB, we have a charge to implement customer service and improve the customer experience. And what that means is that we are really looking to be a highly reliable organization and transform the culture. So while it is about the data tools technology, it's a lot about the engagement. And when we started this in the patient experience area, we went out and we worked with all the major leaders in healthcare, and we asked in Beryl, et cetera, and we asked, you know, what is working, what isn't working, what are you doing right? And we incorporated those. The other thing we did was we asked all of our own providers, and then we asked our customer. So our customer, our charge from the secretary, mine is, you know, transform, make everybody happy, have them trust us, have them use us, you know, no small charge. So the first started is the patient or the customer that we refer to is the veteran, but never just the veteran. I've been a patient, I've been a caregiver, I've been a survivor. It is always the patient, the family member, the caregivers, and the survivors, and I know that was referred to earlier on in some of the conversations that I heard. That is the constellation that we're serving. We're also serving our own staff, and if we don't get that right with the staff, just really quickly, so what we started is using human-centered design that's been referred to. You know, the journey maps, identifying the moments that mattered, identifying once you know those moments, what you do about them, identifying the multi-channels you listen to, including things like we're using Medallia. We have the surveys that we use at all particular key points in the service delivery. We get that feedback within a day and are able to provide it to our facilities so that they get, in the case of just this last year, we had, I think, about almost 2 million feedback surveys with open comments of almost 700,000. Those comments come into the hospital, and when they round, and before that in the leadership meetings, they look at those, and they're able to then, from that, glean what's needed for service recovery for an individual and then for program improvement. We also, that's at the facility level. Nationally, at headquarters, we have groups, IPTs, we call them, it just, you know, a little mini brain trust, and we try to get everybody together to create standards for what does service recovery mean. If you're on one of our 1,000 call centers, do you have a standard greeting? Do you know how long it's going to take if you get a concern or a complaint to be responding to it? What does success look like? How are you going to respond? Even writing letters. We just got an A today from some organization that grades websites on how well you do and is it in English. Who knows? We got an A. We were a D. So and luckily, because my office takes the data tools, technology, and engagement, we have all of those under my control. Now, I don't do contracts, but we're all able to put this together horizontally. So when we touch one piece, for instance, the training with the staff, once we know what's important to the patient and the veteran, we're able to look at what we need to do then to enable and empower the staff. We've trained 80,000 of our staff, our professional providers, in Own the Moment. It is teaching them to be present, to be available, to greet and be present, and to guide the patient in every point of their experience, and it was created by them. I've heard a lot about that, about creating and letting the staff be engaged, asking the nurses what they think. So it's an exciting time. We've learned so much from the private sector. My charge the next year is to get out with our patient experience team and make sure that we keep the momentum going and also share more broadly, because 20% of those I said we have 9 million that are enrolled. We've got another, 10 million who aren't. And where did they go? They go to your facilities. They're using their own, they're using TRICARE, they're using their own private providers. So they're your patients too. We want them to have the best experience with you that they're going to be able to have with us. Right now, our trust scores and our HCAP is outpacing the private sector in improvement. We're up at like 87% plus in trust just in the outpatient alone. And we're doing that across the board with emergency and discharge and everything. So we want them to have a great experience, and we want to refer back and forth. Our new community care enables us to refer people out. One day, same day, emergency. Our veterans can walk into an emergency or an urgent care now just with their own ID card and not have to get pre-approval to do that. So they're going to be out in your systems. They're the ones who are protecting you so that you can be safe and you can do your job and have your families. So you're going to be serving them with us. And I'm just very, very grateful for the passion and the interest that you all commit to making our health care great for everybody. Thank you.
Thank you. So we're going to come back to a lot of the points that you definitely mentioned, but I wanted to turn it over to Joe because the uniqueness of obviously the assembly this time is we sort of collaborated and brought the patient experience world and the marketing world together. So Joe, I obviously want you to go through and sort of talk a little bit about your background and the work that you're doing at Mercy, and then really focus on the that merger, right? That relationship that's being formed now between marketing and between patient experience.
Sure. And thanks, Samir, for allowing me to introduce myself after Dr. Davis. That's a tough act to follow after.
Well, listen,
after that
you already
intro.
got an award, so it was
That's true. That's
sort of leveling you out.
I did grab a box of chocolate today. I hope it wasn't yours.
Oh no.
So good evening, everyone. Thanks for the opportunity to be here and spend time. I think we are going to have Q&A after or later in the evening. Happy to take any questions. But so I spent most of my career in financial services. Went to Aetna for a few years, 3 years, and then I'm now at Mercy, and I wouldn't go back. I wouldn't think of going any other place. It's probably the most challenging job I've had. I was responsible for marketing and transformation in 120 countries for a financial service company, all different time zones. This is harder, but it's a lot more meaningful. It's the most meaningful job I've ever had, and the sense of profound mission is palpable within healthcare. So late in my career, I got here, but I love middle of my career, I should say. But I'm very grateful to be here. So I have the responsibility. I'll start with kind of Mercy, our team, our focus, and talk a little bit about that convergence and do it relatively quickly. Mercy is headquartered in St. Louis. We have a bunch of 40-plus hospitals. That's typically how healthcare providers introduce themselves, how many hospitals they have. And it's kind of ridiculous if you think about it. Our entire operating model is structured around a facility that 4% of our touch points occur in. We're not thinking about the touch points of outpatient visits or clinic visits. God bless you. 80% of our visits are clinic visits, 16% are outpatient, and we get 3 or 4% in our facilities. Our operating model is based around that 3 or 4%. The questions we ask, the data we gather, the processes we input, the workflows we put forward. Said differently, we're set up to displease 96% of the people that we're privileged to serve. So our department converged a long time ago. Acquisition isn't easy, but it's nowhere near as hard as retention and engagement. Those are team sports, and you need to work with operations and finance and clinic and hospital and all your clinical leadership, your service line leaders, to figure out it's expensive to get someone in, it's easier to keep them there, and you do that through the experience. And whether that's technology enabled or an investment in our people to be able to train them and give them the skill sets. Some of our lowest paid coworkers are the ones that create the experience at the front desk and on the telephone with our patients day in and day out. Think of other industries and how they structure that and the incentives that they give. First law of economics is people respond to incentives, right? And We don't think that way in healthcare. We put some of our lowest paid folks in front, and they're having a bad day, that comes off. It doesn't reflect well on the patient, doesn't reflect well on us. From a marketing perspective, we may have spent a ton of money trying to get them into a facility, and all of a sudden we blow it. We just brought them into a leaky bucket. So our team has responsibility for marketing, but I've learned, I guess I haven't learned, the more you complain about something to your boss. I've complained about our 50 million calls a year that go to 141 call centers, 2,971 phone numbers on our website. We have 1,900 fax numbers. We're screaming into the 1990s in healthcare. And you know, if you think about that, where are all those going? Our abandonment rate is 12%. That's 6 million people a year that we have the obligation and privilege to serve, and we're letting them down in their time of need. We have to stop thinking about functional silos, and we have to start thinking about the organizations that we all experience on our phone. We click and we get a meal or a ride or a home, someone else's home, and it's frictionless and it's easy and it's transparent. Those experiences that our patients are having, our consumers are having, are shaping their expectations for us as an industry. It's already happened. Similar to Dr. Davis, we have 1.2 million voices and surveys that we look at, and whether it's age, gender, ethnicity, income level, geographic area, religion, they all come down to 5 basic human needs: access, convenience, transparency, treat me with dignity and respect, personalize the experience, and don't make me fill out the same forms 17 different times. So that's what we're building towards, and that's what our operating model is moving to. As a result of that, our marketing team is 70% is new to Mercy in the past 3 years. 80% of them are outside of healthcare, and 50% of them have STEM degrees. This is about technology enablement and architecture connections of the age of the EHR is long past. We're relying on an EHR, which is a system of record, to deliver a system of engagement or get insights from it to deliver an experience that it's incapable of. So that's why there's so many point solutions that we're trying to figure out how to make sense of. But a non-integrated, non-two-way, bidirectional, non-open API point solution isn't going to make it any better for our patients. So our responsibilities have kind of broadened now to merge with kind of the consumer experience, human-centered design, IT department, marketing, our digital acceleration efforts, and contact center are all aligned, and operational strategy are all aligned under one Office of Transformation, which is a tough title because anytime you show up and you have that behind your name, it implies that someone is doing something that isn't ideal. But that's the reality that we face within healthcare. So I'll pause there and take it down to the next line of questioning.
Yeah, for sure. So I wanted to sort of turn back and sort of continue some of the conversations that you had around, you talked about your patients are not only obviously veterans that are serving your community and so your hospitals, but they're also sort of going out into the community hospitals. What do you feel like you've at this point been sharing with that community, or what are you getting from the community? How are you what's sort of the strategy around collectively having a synergy around that?
Well, one of the things that we're doing is applying that HCD, fact-finding, noting the experience, to our use of the urgent care and emergency care in the community. So we need to go out and map that just like we mapped internally, and understand not only from just the scheduling, the walking in the door, to the record translation and all of that, the follow-up, and we're trying to make sure that we can get our internal surveys available and utilized with our providers that are certified and available. And then the Own the Moment training that I mentioned, that we're going to actually be moving beyond the 80,000, and those 374,000 staff at the VHA health system are going to get it, and we hope that our providers in the private sector, we can also train them in that same thing. And eventually the rest of the department. But we want to use as much as we have internally and make that a seamless experience, externally.
Yeah. So I think, Joe, we sort of started talking about some of the touch points that you mentioned around technology as well. So talk a little bit about how you are sort of embracing and utilizing that sort of methodology, because obviously you said, consumers are coming in with those expectations. So how is that being leveraged, outside of the fact that obviously access is important and that's sort of the marketing angle, but how is that sort of collaboratively working across the organization, and especially on the patient experience side?
Yeah, pardon me. So a couple of thoughts. I think, so Mercy invested in an electronic medical record 13 years ago. We're on one vendor. We have hundreds of millions of transactions. There's answers to questions in that data set we haven't even thought to ask yet. We invested in virtual 10 years ago. Our virtual capabilities were way before reimbursement. And it was really all about how do we had a hard time recruiting specialists into rural areas. When the sisters who founded us went into urban communities, they didn't want to build a hospital, rural communities, they didn't want to build a hospital there, but there was a mining accident in Joplin and people needed help. Civil War outbreak in 1860s, and one side wouldn't help the other side's wounded. So the sisters came in and built a hospital there to help them. So we're in facilities that are, we're in areas that are economically depressed. Virtual was a response to how do we get V-sepsis, VICU, how do we monitor remotely with 1080 technology, looking at pupil dilation and proprietary algorithms on septic shock. We have one of the lowest septic shock rates in the country. To intervene before that happened. The whole model for virtual is, the goal is for us to take care of someone when they have a minor illness rather than present themselves in an acute setting that we're not going to get reimbursed for. Every macroeconomic trend or factor goes against us. We're in states where Medicaid wasn't expanded. Our population is getting older. Our Medicare population is getting older, faster on average in the country. Some of our communities, 35% of the people will be over the age of 65 in just 3 years' time. Medicare is pretty tough to make money on for most health systems. It's often subsidized with commercial rates. So virtual is a way for us to, from a population health perspective, it's kind of a dual purpose. It fulfills our mission to serve and to serve the least in our communities, but it also helps us to get ahead of some of those costs that we can't afford. Healthcare can't grow into its cost structure. We're 18% of GDP, 3 times what we spend on our military, and our child mortality and life expectancy rates are not great compared to other OECD countries. So what we're trying to do through technology is be able to better manage populations in a more cost-effective way and in a manner that's better for our patients. We have a program called V-Engagement, which, so for our highest, our sickest patients, a lot of comorbidities, we monitor them remotely 24/7. They have iPads, scales, pulse oximeters, all this stuff, and we take care of them. Their patient satisfaction rate, our scores are at 98%. We save on average per patient about $6,000 a year. I'll give you one example. Mark Twain National Forest is in the middle of Missouri. We had a veteran who lived there 25 minutes from a road, let alone, I think he was 95 minutes from the closest hospital. In 1 year, we had to airlift him to our emergency department 13 times. He was a Vietnam vet, and he said he spent more time in Mercy helicopters than he did in going into hot landing zones. So we put him on this V-Engagement program, which is part of Mercy Virtual, and the following 2 years, not a single ED admission. We saved hundreds of thousands, if not more. So it's not about the reimbursement, it's about managing the costs, but managing the lives of those that we're privileged to serve. So that's what that's about from a technology perspective. Our operating model is shifting rapidly to digital first, virtual second, physical as a last resort. 80% of our touch points in the clinic, a lot of those primary care visits can be handled in an asynchronous manner through technology. When we look at how much it costs for us to schedule an appointment online, we have about 1,000 a day appointments scheduled online, but that's still only 4%. It costs us about a nickel, and it costs us about $13 for a phone call. So if we start thinking about how do we not grow into our cost structure, but start treating people in a way that they want to be treated, they're already conditioned by other industries to go to their phone go to their tablet, go to their computer. So we're trying to build that framework, and part of the challenge is the point solutions that we have across healthcare. We have so many separate clinical pieces, applications of software. We have so many operational pieces of software, and we have so many consumer-facing. Mercy has 260 consumer-facing pieces of software, and 12 of them are connected to our electronic medical record. So if you think about the power of data and data architecture and governance and technology architecture to have that data inform your operating model, that's the path that we all have to head down, in my perspective.
Yeah, and that story about that veteran, I know it's been published and talked about. I heard somebody else present it. I think there's even videos that you guys created on that. So I think it's a pretty phenomenal story, and the virtual services that you guys are doing, I think it's, and the medical at home service is really well known.
Thanks.
So opposite, sort of similarly, you guys are obviously going through a massive technology transformation with your move from Vista now, I know David and I were talking about it earlier, to Cerner, and the fact that the DoD will also have Cerner and the VA will have Cerner, and then there'll sort of be a total record, if you want to call it. Talk a little bit about the technology journey there. I know, and then similar sort of issues or opportunities that exist, but obviously with the VA standardizing, right, as one entire entity on one platform. What does that mean, and what does that look like in the future for you in terms of patient experience as well?
Well, the health records are one thing. When I enlisted in the Army, which was, let's say, in the 80s, everything was paper and pencil, and so I got a stack, and when I got out, it was a while later, but the stack was, so you can end up with 40 pounds of paper that you're carrying around, and that's not a good patient experience, to say the least. So the trick has always been to integrate the two major systems that serve that individual from the point of accession when they join to the point of memorialization and beyond, because their survivors continue to be eligible for benefits, and they do need to look at the records. So it's been a huge challenge. We're finally getting around, as you alluded to that. And we'll see. It's going to have a bunch of bumps. It probably won't be done when we want it to be done, but it will get done. And that's an important commitment. Important also for the ratings and the access to benefits that you are looking back at what actually happened on the battlefield, things like that. But the technology being used, not just the records, but the technology in the way we're using, like reducing our number of contact centers and the call centers, and you referred to, I love the way you referred to the faxes and stuff. We know that 70% of the calls that we get over almost 2,000 different call centers are just simple questions. We now implementing a 311 that is one single integrated system that can be answered with the same knowledge management base by everybody, that you take the majority of the calls out so people can spend time with somebody who can actually listen and triage them to the place they need to be. Using the distance technology, we're doing our telehealth, telemedicine, telemental health especially, now in Walmarts. We've just developed those private spaces in Walmarts that we can have, and that veteran, given where he was, he could not probably also get to the Walmart. Yeah. But a lot of our population can and do get to places like that, and we're trying to partner. We have an agreement with Walgreens, you know, where to supplement our pharmacy. So trying to think creatively to bring it to your home. We have an initiative that is called Choose Home that I run, and it is doing a pilot to ascertain what you need with case management integration and how you involve all the partners in the community, Red Cross, volunteers, faith-based, et cetera, to make sure that that veteran, our aging population, doesn't have to go to be institutionalized in the last days. So it's using it smarter across the board, not just the electronic health record, and using it in ways that make it also easier for our providers, because that's key. I just have one experience we had yesterday, and I appreciate so much how, you know, I want my healthcare like my iPhone. However, I want the new phone, though. I do need to pay for
You want
that.
the 11?
I know, it's going to be worth it all.
Yeah, okay.
But what I do want, something that's irreplaceable is that engagement. So yesterday on our spinal cord unit at the Denver hospital, we had the Broncos come. One of our patients was was post-recovery, but waking up in his room for the first time after his surgery. He wakes up and sees 3 Broncos in their orange jerseys standing.
He thought he was dreaming, right?
Oh, he freaked out. He out crying, big eyes, just like, oh my God, are you telling? Is it the drugs? Is this real? And so not only did he have a wonderful experience before this on the ward and with the staff there that are exceptional and have all the nice technology, thanks to some people here in the room, but he had an additional engagement with the community base that just made all the difference to his healing and his family that you can't get if you just rely on the technology.
Yeah, no, absolutely. I mean, people process, right? We talk about. Okay, so we're going to wrap up soon. We're going to open it up for questions. Before we do, we spent a day here, so I want both of you to tell me what's been your favorite part today about the conference. The chocolates you got from the show?
The chocolates, no.
Okay.
The favorite part was listening to everyone it was reinforcing what we hear all the time, and the importance of in this business right now with the patient experience, be your own patient, be your own customer, walk the post, as we like to say, get out, understand. But my favorite part was telling him to call his mother.
Oh, okay.
Yeah, because that gets down to what you absolutely need to do. She's not going to give up the soy sauce, but she will listen to you if you tell her she cannot have it the night before, so her legs won't be swollen.
Where's Peter Wong?
It's simple things. Yeah, simple things that we do. It's a great group you have here.
Yeah, great. How about you, Joe? I know you haven't been here like the whole day, but half the day at least.
Yeah, I just came in from Dreamforce in San Francisco. If you guys are familiar, that's me and about 180,000 other people
Closest friends.
Go to the Salesforce annual conference. It's almost outlandish. Alicia Keys showed up on stage. Barack Obama pops out. I mean, it's crazy. But as far as today, just being here, the conversations, I think the conversations at dinner was great. Obviously, being honored with this award was awesome, especially given the folks that we have in the room here. But just the opportunity to learn from each other. There's such a need for that for us. And I think, I was sharing this earlier with someone. Career in financial services for 20 years. At events like this, I'd have to fill out a regulatory form. I didn't talk about any forward-looking statements. I'd have to go to compliance and say I met with competitors. And I remember my first healthcare conference. During introductions, people were going, my budget is X, and here's my 3 most important things strategically. And I'm thinking, we're all going to get arrested. What are you people doing? But I think there's such a willingness to share here, and that's the benefit of these sorts of things. So I'm grateful for that. So thank you.
Purpose of community for sure. All right, Kara, you want to open it up to Q&A?
Yeah, so I'm Dirk Schabler. I work for Bayer and run our digital innovation business there. So I'm looking at China and how they try out some of the new ways to deal with healthcare. And apparently they set up this entire city that is totally digitized and takes a whole new approach towards how you use data from patients, meaning that there's no privacy, and there's no protection, or there's no secret anymore. Is that something that you, for Lynda, is this something that you look at as well when you kind of look at new ideas on how you can actually deploy those? Yeah, I mean, when you look at the access that you have to data from the population that you're serving, basically?
Well, I hope I understand the crux of the question. First of all, when I talked about us trying to understand the best practices in patient experience and customer service, et cetera, we did not look to China. And I wouldn't particularly, but others might. But what we're extremely concerned about both for the individual, obviously the PII and the privacy and everything else, even with the integration of the records, and that's a key to it. But what we are looking at in terms of, one of the questions came up was about the demographics and the ability to serve special populations and things like that. So we have an initiative that is the Million Veteran Project that is doing the genomics and the genetic mining, if you will, of all of our different veterans, and then making that data available for research across the world. We're also just started a center of excellence for veteran research that will also include their caregivers, et cetera, and children and youth, and the long-term longitudinal consequences for them of trying to support somebody who is in and out of medical care settings. So we'll look anywhere, but I'll just have somebody else be the technical geek that goes to China. Been there, done that.
All right. Anyone else? As I do with my kids, 5, 4, 3, 2, 1. Okay, that's a wrap. Thank you.